Hi, everyone. Thanks so much for joining me on today's webinar, all about skin cancers 101. And also, I am available to answer any questions that you all have. And this live webinar will be on my Facebook page, The Skin Reel, so that you can listen to it at a later date if you happen to miss the live streaming. All right, just making sure everything is on and we're good to go. All right. This is my very first webinar, so thank you guys for being here. I am Dr. Mina. I am a board certified dermatologist and dermatologic surgeon. I practice in Atlanta, Georgia, and I also am the host of a podcast and blog called The Skin Reel, and I can be found at www.theskinreel.com, where I really enjoy educating people about not only skin cancers, but skin conditions, and making sure that people have real, factual, scientific backed information for their skincare needs. As a Mohs surgeon, I see a lot of skin cancer, and I am also a part of a lot of Facebook groups where there are a lot of questions from you all about skin cancer. And so I wanted to do a mini course on it to help you all understand what skin cancers are and kind of dispel some of the myths and give you some factual, truthful information. Skin cancers are the #1 type of cancer in the world, and they are on the rise. And that's due to a lot of factors. The most common type of skin cancer is called a basal cell carcinoma. And some of you may have even had one of these. The second most common is a squamous cell carcinoma. And this is especially true in patients who have had a transplant, like a kidney or a heart or a lung. Most people are very familiar or have at least heard of the term melanoma, which is another type of skin cancer. However, it is not one of the top 2 most common. And then we have some more rare skin cancers, but we are seeing that these are also on the rise. And those are things like Merkel cell carcinomas, atypical fibroxanthomas, and angiosarcomas, just to name a few. So just be aware there are some other ones out there. Excuse me. Hands down, the most common cause of skin cancer is ultraviolet radiation. Okay, so again, that's why you always hear dermatologists talk about stay out of the sun and protect your skin. Other factors are things like immunosuppression. So if someone, again, is a transplant patient and they're on strong medications to lower their immune system, they are at a higher risk. And there are also some genetic components that people are just born with. Why are we seeing this rapid increase in skin cancer? It's probably multifactorial, but our our sun exposure habits have changed over the past decades, centuries for sure. We are spending more time, more leisure time outdoors, and also having a tan, at least previously, has been seen as healthy and youthful. We are also living longer, so we have more years to develop skin cancers and more cumulative sun exposure. We also are seeing a depletion of the ozone layer, and this is especially true in places like Australia, where the skin cancer rate is really, really high. And then there are other factors we just don't know about. 1 in 5 Americans will get a skin cancer, and there are over 5 million cases of basal cells and squamous cells in the US each year, and 1 in 50 Americans will develop a melanoma. So that's why this is so important, and that's why I'm so passionate about educating people about skin cancer and prevention. When skin cancer is caught early, it is very, very, very treatable. And again, this is why prevention and early detection is so key. All right, so we'll start off with basal cell carcinomas because, again, that's the most common and it's the one that you are most likely to get. It's very, very common here in the US. We tend to see it in middle-aged and elderly people, but I have even seen it in 20-year-olds. And we tend to see these on sun-exposed areas. So things like your face, your ears, your neck, less likely your trunk, your abdomen, parts of the body that tend to be covered with clothing or not as sun exposed. And I get this question a lot from my patients. Once you've had one skin cancer, you are predisposed, or excuse me, you are at a higher likelihood to develop another one. And I sort of tell my patients that's because it's from sun damage. So if the skin on your nose has seen enough sun to get a basal cell, then the skin on your forehead probably has as well. Basal cells tend to have a very slow progressive growth phase. So a lot of times people will notice a little spot and they don't think much of it, and it's there for years before it really starts to change or grow or do anything or simply be detected. They tend to grow very slowly over months to years. And sometimes people will say, well, what if I didn't do anything? What if I just left it here? And I just let them know that the cancer will continue to grow. The chances of a basal cell metastasizing or spreading to other parts of your skin, or excuse me, other parts of your body is really low, but it's going to be very destructive. It's going to eat away at all the skin where it's living. And if that happens to be by your ear or your nose or your eye, guess what? It's going to also eat away at that organ as well. These are just some examples of basal cells that have been neglected. They've been left to grow. And as you can see, they are quite large at this point and extending down into the ear canal and into the soft tissue around the eye. So again, much easier to treat early rather than waiting for it to be at this very late stage. Not all basal cells are created equal. And I think sometimes people think, oh, basal cell, it's no big deal. It's not going to kill me. It's nothing to worry about. And there certainly are some basal cells that are like that, that I call them run of the mill, very easy to scoop out and be done with. However, there also are some more aggressive subtypes of basal cells just to be aware of. They're not all created equal. And if you ever get a path report that says you have a basal cell, you may notice some of these aggressive subtypes. And that would be something that says infiltrative, basosquamous, or poorly differentiated. And when I see that, it is just a little light bulb in my head that this may be deeper or wider or more involved than what we can see on the skin surface. Now we'll shift over to squamous cell carcinomas. This is the second most common type of skin cancer. Just like basal cells, it tends to arise on skin that has seen some sun, okay? And a lot of times they arise from these precursors called actinic keratoses. And some of you have maybe been to the dermatologist where they freeze those spots off or they tell you to put a cream on. Those actinic keratoses are those little gritty, rough areas on the skin, and some of them can go on to develop into squamous cells. Just like with basal cells, we tend to see these on sun-exposed areas of the face, lips, ears, hands, but we can also see squamous cells on fingers, nails, and genital areas. There are some times where we see more squamous cells than basal cells, and this tends to be in patients who are immunocompromised. And by immunocompromised, I mean someone who is on or someone whose immune system is suppressed. And that tends to be people who have had an organ transplant, like a kidney, heart, liver, lung, things like that. We also see more squamous cells in patients who have darker pigment. So someone whose skin is not as light or fair, they tend to have darker skin. When we see squamous cells on the lips or the hands or the genital regions, this tends to be HPV related, which is a common virus. And we also see more squamous cells in patients who have had phototherapy, perhaps for psoriasis or eczema, or someone who has had radiation. And a number of patients I see have had radiation as teenagers for acne back before we realized radiation can actually cause cancer down the line. Sometimes my patients will say, well, which is worse, basal cell or squamous cell? And I try to explain to them that it really depends. There are bad basal cells, bad meaning more aggressive, and there are also more aggressive squamous cells. And those more aggressive squamous cells have a higher chance of spreading to other parts of the body, including lymph nodes. So squamous cells do have a higher chance of spreading, more so than basal cells. Again, not all of them, but when that does happen, they tend to have some high risk features. They either are recurrent, meaning they have been treated before and then have come back. They tend to be bigger than 2 centimeters, and that's about a little under an inch. They also tend to be very deep. So when we're in there doing surgery on them, we are having to cut pretty deep into the tissue to get around and under it. Sometimes they can be what we call poorly differentiated. And that's when the cells have become so bad, they don't even resemble the original cell they started from. They have morphed and mutated so much. More aggressive squamous cells also tend to wrap around nerves, and we can see that under the microscope when we're doing surgery. And then again, patients who are immunocompromised, they tend to have a higher risk for a poor outcome or a squamous cell that's going to spread. So basal cells and squamous cells, common areas and also high risk areas where we see them are on what we call the H zone of the face. And you can see in this diagram here, it's going to be the sides of the face, around the eyes, the nose, and the mouth. That is considered the H zone, and those are more high risk areas. And they're also trickier areas to treat because we've got important structures there, like your lips, your eyes, your nose, your ears. And I try to explain to my patients that, again, skin cancer is not one size fits all. Not every basal cell is going to behave the same. Not every squamous cell is going to behave the same. We really have to look at sort of the whole picture. We have to look at what are some of the risk factors with the tumor. Again, is it big? Is it aggressive? Is it deep? Is it around nerves? We also have to look at high risk factors in the patient. Have they had a ton of sun damage over the years? Are they still using tanning beds or getting sunburned? And we need to look at their overall health. Are they healthy? Or are they immunosuppressed from something like CLL, which is a type of leukemia, or from having a transplant? And we really, as dermatologists and Mohs surgeons or dermatologic surgeons, have to take all of these factors into play because, again, skin cancer is not one size fits all. One basal cell on the nose in one person can behave very differently in someone else. Fortunately, we do have a number of treatment options for these non-melanoma skin cancers. And again, when caught early, they are very, very treatable. And this is not in any particular order, except maybe least invasive to most invasive. But you can start off with a procedure called an ED&C, electrodesiccation and curettage. Sometimes I'll just call it a scraping. And this is great for very superficial skin cancers, ones that have not become invasive. And we numb it up, we take a sharp curette, and we scrape the tumor off the skin. The tumor tends to be a little bit mushier than the surrounding skin, and that's sort of our guide. The downside of doing this is that we don't have confirmation that we got it all. We really just have to go by feel. So it does have a higher recurrence rate than surgery or Mohs surgery. However, it is a good option for very superficial skin cancers and in someone who may be a slow healer, and it's kind of a quick in the office procedure and you're done. Other treatment options that maybe some of you are familiar with is using a chemo or immunotherapy cream. And in the US, at least, this is called 5-fluorouracil or imiquimod. These treatments are, again, just like with the ED&C, most helpful for non-aggressive and superficial skin cancers because the cream is not going to penetrate very deeply into the skin. So it's great for those superficial ones, again, in someone trying to perhaps avoid surgery or maybe isn't a good surgical candidate. The downside of this is that unlike the scraping or the ED&C where you come in, 15 minutes later, it's all gone, this requires daily, if not 2 times a day, treatment for a number of weeks, at least 6 weeks for skin cancer. And when you're applying it, you turn bright red and crusty. Anything that has any skin that's sun damaged is going to light up. And you can see for this gentleman here, it looks like he's using it more to treat precancers, but his whole face has had sun damage, and so it all lights up. So you have to weigh whether you're okay with being kind of red and crusty for several weeks to months with this treatment option. However, it's certainly something I use and a great tool to have for certain skin cancers in certain patients. Radiation therapy is another option. In the past, superficial radiation therapy was widely used. And then as Mohs surgery and surgical practices improved and got such high cure rates, we saw sort of a fall off with superficial radiation therapy. However, in some patients, this does have a role. Just be aware that radiation does cause cancer in the long term. So not a great option perhaps for someone who is young with a long life expectancy. It's also depending on how deep you go. If the radiation is just treating the top of the skin, then there is a chance that any tumor below that will evade destruction. And so the recurrence rate can be higher if the therapy is not deep enough. Sometimes patients will want this option because they think it's less invasive, it's not going to leave a scar, that it's sort of the easier option than surgery. And I just have to remind them that radiation has its own issues and it isn't scarless. You can see this patient here has a lot of what we call radiation dermatitis. His skin now has changed forever. It's going to have more of a scarred appearance with those blood vessels, and that's permanent. That's from the radiation doing its job. Unlike surgery where you come in for one day and then it's done, with radiation, you do have to be seen multiple times a week over several weeks. And again, it's not a great option for some of these really aggressive tumors. if you're not going deep enough. I certainly use radiation therapy, and there are some instances where it would be my first line option, but more commonly, I'm using radiation in patients who have already had Mohs surgery or surgery, and they've got such high risk tumors that I want to give them that extra boost, extra cure with radiation to prevent the skin cancer from coming back. Probably one of the most common ways to treat skin cancers is with surgery, and that can be done with what's known as a wide local excision, where you take a several millimeter margin around clinically what you see, you cut it out in a little diamond shape, you stitch it up, you send it to the lab, and you get a report back in about a week. This can be quite effective, especially in areas like arms, legs, the trunk, where you don't have delicate structures like ear, nose, lips, things like that. However, it's definitely a bummer when you get that path report back and it says you didn't get it all, and now you got to cut out that whole scar again. So you just have to think about that. It is a possibility, and why I don't typically do this on areas like the face, the head, the neck, hands, areas like that. When you have a regular excision, the pathologist is going to slice it up like that top picture. And I tell patients to think of a loaf of bread, of sandwich bread that's sort of sliced vertically. The pathologist pull out a few of those slices, they check the margin, and then they give the report. Now, some of you may have heard of Mohs micrographic surgery. And with this technique, it is actually processed differently. It's called en face processing, which is where, think of a pancake. Instead of slicing the pancake like a loaf of sandwich bread, you are actually going to just put your head down and look at that whole pancake sort of from the top down. So you're seeing 100% of the margin with the en face processing. This technique was developed by Frederick Mohs, and I just did a whole podcast episode with my business partner, Dr. Baucom, on Mohs surgery. So I'd encourage you to go check that out if you're interested in knowing the details of it. But it really has become the gold standard in treating skin cancers, especially on the head and neck. That's because the cure rate far surpasses any other treatment we have. It's also tissue sparing. So unlike the wide excision where you just take a 5 millimeter margin around the whole thing, with Mohs, we take a very narrow margin and then we check it under the microscope, and we only remove skin where there's tumor. It also is evaluating 100% of the surgical margin as opposed to the standard bread loaf pathology processing, which looks at about 1 to 2%. And I really strongly recommend Mohs surgery when it's in areas, especially if they're cosmetically or functionally important, around the eyes, the nose, the mouth, the ears. It's also great when the tumor is recurrent because you can really get in there and see, well, where is the tumor? What's it doing? What's it looking like? And also for large tumors, it's really the gold standard as well. Anything over 2 centimeters, which is just a little bit under an inch. Sometimes patients are surprised when they come in for what seems like a very small spot, and next thing we know, I've had to go back 3 times and it's much bigger. And that's because skin cancers can be like icebergs. What you see on the surface is just the tip of the iceberg. We need to really get in there and remove all of that tumor that could be hiding out under the skin. And there's really no way to know if it's doing that until you get in there and look at it. So this is just an example. This surprised me because clinically it did not look like a very aggressive tumor, but certainly it was deep, it was aggressive, and it extended very widely. And this is something that we see Pretty commonly. It's not something that's so rare. We see it fairly often. And again, if you're interested in learning about Mohs surgery, I definitely encourage you to listen to my recent podcast on it with my business partner. But the general gist is the patients come in, they're awake, you mark out where the tumor is, cut it out like a little pancake. It gets frozen and sliced in the lab in our office. We have it mapped out. So if there is tumor under the microscope, I know where that is on the patient, and I can very easily go back, take another scoop around it, and then the process starts again. And we do that until it's all out. Not to belabor Mohs, but some of the advantages, it's considered here in the US, it's a bundled procedure. You have one physician removing the tumor, reading the pathology, and repairing the lesion all in one visit. It's outpatient. There's no OR. There's local anesthesia, no general anesthesia, which can be quite dangerous, especially for older patients. Lowest recurrence rate out there, and a very cost-effective way to treat skin cancer, especially when it's one physician doing all three steps. And at least here in the US, most surgeons do thousands of these cases all the time, and there really is no need to see a plastic surgeon who is most likely not doing these closures on a day in and day out basis. Mohs does have some disadvantages. It can be a long day for patients. The average is 1 to 3 hours, but I certainly have some patients that are with me all day. Some areas are difficult to access in a clinic. So if something is really tracking down the ear canal or deeply around the eye, that can be difficult. And patients can have anxiety about this for sure. And one of the ways that in my practice we combat that is by giving Valium and anxiolytic, warm blankets, and really just taking our time helping patients feel comfortable, feel relaxed, because it can be nerve-wracking. With most surgeons in the training nowadays, most surgeons are really skilled at doing all types of flaps, grafts, linear closures, and sometimes the best closure is no closure at all. I call it Mother Nature, and that works really beautifully in some locations as well. The last skin cancer that I'm going to talk about today, and one that I think most people are most familiar with, is melanoma. And this is one that a lot of people say, well, melanoma is the deadly one, basal and squamous cell not so much. And they're right in some respects. 1 in 50 people will develop a melanoma, which is one of the deadliest types of skin cancers at some point in their lifetime. And melanoma can be really, really sneaky. These are 2 examples in these pictures of melanoma. So on the one with the tattoos, that one may be more of a melanoma that you think of when you hear the word melanoma. It's a dark spot, it's big. And this patient actually came to see me for a cyst removal, and I really had a hard time focusing on his cyst because I was so concerned about all the moles he had on his back. And the one on the left here actually was a melanoma. This patient on the cheek was coming to see me for a melanoma, and she had just that ill-defined brown patch below it. And I was concerned that that was also part of her melanoma, and did another biopsy, and sure enough, that was as well. So again, melanoma is tricky because it can have some variations. It doesn't always read the textbook. Classically, as dermatologists, we will discuss with our patients the A, B, C, D, E's of melanoma. And this may ring a bell for some of you. We tell people to look for asymmetry. So a regular benign harmless mole is going to be symmetric. You can draw a line down the middle, fold it in half, and it's going to match. Anything that's asymmetric is worrisome. B stands for borders. So if the borders are nice and even, that's a good sign. It's when the borders get a little irregular, a little smudgy. I tell people I want to be able to draw a pencil or marker around the mole. If I can't really tell where it starts and stops, that's a little concerning. C is for color. So moles should either be one uniform color, or if they're two colors or a different color, it should be done in a symmetric way. So sometimes we'll see almost like a fried egg appearance, where it may be a little bit darker in the center, but then evenly lighter around the periphery. That's allowed, but when it's a little very irregular with the colors, maybe black in one area, white in another, pink here, that's concerning. D stands for diameter. So anything bigger than about a pencil eraser catches my eye. I want to look at that a little bit closer. And then E is for evolving. So any mole that's changing. Most melanomas, believe it or not, come from brand new moles that you've never had before. So if a patient tells me, all of a sudden at 45, I've got a new mole on my leg, that's a little concerning to me. If a patient also comes in and says, this mole's changed, it always had this little dot here, but now it's got another little dot here and it looks like Mickey Mouse ears, I'm going to take that into consideration. And even if it looks normal to me, I may even biopsy that, because moles really shouldn't be changing and evolving when you're an adult. So this is just kind of a framework for melanoma and how to detect them. Again, melanomas are sneaky and tricky, and they don't always follow these rules. Just like with the other types of skin cancers we talked about, risk factors for melanoma are number one, ultraviolet exposure, so AKA sun damage. Unlike the other skin cancers, melanoma does have some other genetic components. So a first degree relative with melanoma is going to put you at a higher risk for developing a melanoma as well. So if your mom, your dad, or siblings have had melanoma, you want to get yourself checked as well. If you've had one melanoma, you are at a higher risk for developing another melanoma. There are also some people who have what's called dysplastic nevus syndrome, where they are covered with dark, kind of funny looking moles, and they are at a higher risk for some of those moles actually becoming melanoma. People who tend to have fair skin, light hair, light eyes are at higher risk, as well as men, people who are immunosuppressed, and then also indoor tanning plays a big, big role. And we'll talk about that in just a sec. These are just a few pictures of melanomas that, again, might very easily have gone unnoticed on someone because it doesn't really look like much. You may have thought, oh, I just cut myself or scraped myself. But on closer inspection with a light that we call a dermatoscope, we can see sort of this variation in pigment. It's a little bit blue in the center, it's brown on the left, darker at the bottom, pink in some areas, and this was actually an invasive melanoma. All right, so let's talk about indoor tanning. I think at least nowadays, people know it's probably not good for you, but does that stop people from doing indoor tanning? No. It's a $5 billion a year moneymaker in the tanning industry. So people are still going to tanning beds and tanning. And that's really, really worrisome because it increases your risk of melanoma by 75% for those who tan before the age of 35. And that's why I always educate my teenagers to not do indoor tanning, to not go tan before prom or homecoming, because there is such a high risk of melanoma when they do that. You also are increasing your risk of basal and squamous cells as well. Sometimes, though, for my younger patients, I find when I warn them about the risk of skin cancer, that doesn't really hit home. So, what I also tell them is that indoor tanning is going to prematurely age your skin. You're going to look older than all your other friends when you do indoor tanning. And sometimes that works a little bit better. There have been tons of papers and studies verifying the risk of indoor tanning. And this paper, I think, is great because some people may say, well, I can tan. When I go to the tanning bed, I never get burned. So I must not be at risk, right? My skin is protecting me. I just get this beautiful bronze look. But that's actually not true. You are increasing your risk for melanoma even when you are not burning at the tanning bed. And this is just to show, again, melanoma is similar to basal cell and squamous cell in that they are not just cookie cutters, that you can have some basal cells where patients do really well and some where they do very poorly. Similarly with melanoma, when we catch it early in those early stage cases, we can almost say we're going to cure you. However, when melanoma is caught late and it's allowed to become very invasive, or it has become very invasive, then the mortality rate is really, really high. And that's what just is kind of fascinating about melanoma, that you can have some patients do really, really well. However, a lot will do really poorly. And again, it's all about early detection before we allow the melanoma to become deeply invasive. So those are kind of the three most common types of skin cancers you will likely encounter. And now that we've sort of gone over that, I'll just go over some of the ways to protect our skin from the sun and to help prevent skin cancers. And then I'll also take some questions that I'm seeing pop up. Number one, prevention is key. If you can prevent sun damage in the first place, you are going to drastically reduce your risk of developing these skin cancers over your lifetime. The best way to do that, stay out of the sun. And if you're going to be in the sun, protect your skin. You can do that a number of ways. Sunscreen every day is what dermatologists recommend, SPF 30 or higher. You want to make sure it covers UVA and UVB wavelengths. And you want to make sure you reapply after sweating, swimming. Just remember, you can't put it on once in the morning, go spend the day at the beach, and think you're still going to be protected. I also love sun protective clothing because then I don't have to constantly be rubbing lotions and creams on me, which I find can be annoying. So I always have a hat with me, and I really love the rash guards when I'm at the beach with my kids, I'm outdoors, or I might have a little cover up that I can drape over my shoulders if I know I'm going to be outside in the sun. When you're applying sunscreen, I get this question a lot. A lot of times people do not put enough on because, again, no one wants to feel like they're caked on. But really, if you are putting adequate sunscreen on, it's going to be 2 teaspoons for your face, or an ounce, which is about a shot glass or a golf ball size, for your whole body. So just make sure you're using enough. And this is scientifically backed. This is not, a dermatologist in cahoots with the sunscreen makers, but there have been really well-designed studies showing that sunscreen use will decrease your chance of developing skin cancer, and that there are more melanomas in people who use less than a 15 SPF or none at all. And that actually using sunscreen can decrease your chance of melanoma by almost 40% in women, which is huge. Sunscreen also is going to keep your skin looking beautiful and healthy. Again, it's going to prevent photo aging, premature aging. So not only does it help with skin cancer prevention, but also for anti-aging. Another thing to do to help with prevention and early detection is to get a skin check from, if you can't see a board certified dermatologist, at a minimum, see your primary care doctor. And a lot of times they can help direct you if they think something looks worrisome. We don't necessarily recommend skin screenings on every single person in the world every year. But if you have a history of sunburns, if you have a personal history of skin cancer or a family history of skin cancer, lots of sun exposure, or a lot of moles, then you do want to get in, see your dermatologist. And I think it's a good idea, if you're unsure, go have a check, have them evaluate you, and they'll tell you whether, you know what, based on your history, I don't need to see you unless something comes up. Or they might tell you, nope, we need to see you about annually. One medicine that's kind of exciting for prevention, because again, I get a lot of patients saying, what can I do besides, prevention and skin checks with you? And for a lot of my patients, when they're older, they sort of feel like, well, prevention has sort of gone out the window. What can I do now? And there is a B3 vitamin, nicotinamide, that has been shown in some good studies in Australia that when taken twice a day at high doses can reduce the incidence of skin cancers and precancers. So that is something to talk with your doctor about if you are developing a lot of skin cancers year after year. This might be a good option for you as well. I also recommend self skin exams. So just like we recommend self breast exams and other exams, checking your own skin about once a month can be really, really helpful. It helps you identify things on your skin so that if something new appears, you're aware of it. And women are oftentimes better at detecting melanoma than men. And it's also important for women, if you have a spouse or partner, they may not be checking their own skin, and melanoma is the most common on the back in men. So make sure you're looking at your spouse's back if they aren't on their own. And once you've had one skin cancer, whether it's a basal cell, squamous cell, or a melanoma, you are at a higher risk of getting another one. So again, early detection is key. So check your skin about once a month, grab a mirror, look at the back of your legs, and make sure you're seeing your dermatologist for those total body skin exams as well. Let's see. And just briefly to kind of finish this up, some people think that if you have darker skin, you are not at risk of getting skin cancers, including melanomas. And while your risk may be lower, you actually can have a worse prognosis. And so it's very important for people who do have darker complexions to also be aware about skin cancer, because a lot of times their cancers are identified later and they can have a worse survival. And they also can get melanomas and skin cancers in areas that someone who has very fair skin or light eyes, light hair will not, including the palms and soles of the feet. So always at your skin exam, make sure they are looking at your hands, the bottoms of your feet and your hands as well. This is just an example of a nail melanoma on a gentleman. All right, so I know that's a lot of information. Hopefully you guys can go back and listen to it again if you like. If you want further information, I do have a podcast and a blog, theskinreel.com. You can also go to the American Academy of Dermatology, which is aad.org. Find a board certified dermatologist in your area, as well as these other organizations, American College of Mohs Surgery and the American Society for Dermatologic Surgery, for more information. All right, I see I do have a couple questions. So if people want to just type in the comments, if there are some other ones. But it looks like Kirsten was saying, Does phototherapy, light therapy for psoriasis put you at risk for skin cancer? So that is a great question, and it depends on which type of phototherapy you received. So most phototherapy nowadays is narrowband UVB phototherapy. And that actually does not, it's such a very narrow wavelength that you are actually not at increased risk, or not at a significantly increased risk for skin cancer with that. However, anyone who has had PUVA, UVA with Sorlin light therapy, which is something that was done more in the past than it is today, but that does put you at an increased risk for skin cancer. So if you had PUVA when you were younger, you are at a higher risk of skin cancer. Yes. Mary, did you have a question? Okay, so this is great. Are chemical peels a possible treatment for skin cancer? So the answer is yes, absolutely. And I feel like we use chemical peels a lot for photo rejuvenation, and I'm a big fan of chemical peels, but they actually can be used for skin cancer prevention. And I should have put that in my slides. Um, what chemical peels do, and again, it depends on which one you're doing, it really needs to be at least a medium depth chemical peel. And what it does is you apply an acid to the skin, and then that all of the top layers of skin sort of universally are sloughed off. And so that will also include areas that have precancers or very early skin cancers. I don't think any dermatologist would use a chemical peel to actually treat a skin cancer, but it is a great option for removing precancers. And what I like about it over the creams is that it's a kind of one and done deal. You come in, you get it done, you heal over the next week, and you're done, but you don't have to be kind of red and crusty for weeks on end. The negative with chemical peels is that insurance does not pay for it. They know that we use chemical peels for photo aging and skin rejuvenation, and so it's pretty tricky to get it covered. So that's one disadvantage. But if someone is interested in more of the rejuvenation benefits, then I think it's a great option. Okay, so Kirsten said she had a basal cell removed, but she wants to do phototherapy. So that's definitely, I don't think you are, that's a total exclusion for doing phototherapy. You would just want to talk with your dermatologist to make sure that it's the best option for you, that you really do need it. And again, I would recommend the narrow band over PUVA because we know that does increase skin cancer risk. So here's a question on how likely is a basal cell going to recur from a surgical excision versus a Mohs procedure? And it's hard to answer that question without knowing a little more information. For a primary basal cell that's never been treated before, the cure rate with a surgical excision can be really, really high, assuming the path report showed that the margins were clear. And if it was not an aggressive basal cell. Now, the cure rate might be a little bit lower if it was an infiltrative or aggressive basal cell, and perhaps the margin was not wide enough. But I can't fully answer that question without knowing a little more information, but a cure rate with a surgical excision can be quite high. It just needs to be on the right, making sure the margins are adequate, the path report shows that the margins are clear, and it's not a very aggressive skin cancer or basal cell. All right. Well, I really appreciate you guys listening, and hopefully I can do some more of these. So if you are interested in a particular topic you'd like to see a webinar on, definitely send me a message. I'm at Dr. Mina Skin, and you can also find me on my Facebook page, The Skin Reel. Thanks so much.